Hi, this is Tom O of the University of Iowa. I'm going to show you an IOL exchange. We had a PanOptic lens with a lot of dysphotopsia. We're using this flat cannula to get the dissection started between the capsule and the lens. But here, this particular haptic, we're having trouble. Of course, you always want to use the viscoelastic to get the dissection going along the area of the haptics, because that's the point at which the adhesion is most difficult with these explants. We are unable, though, to really get this distal portion of the haptic free. You can see that here it's still pretty well attached, and it's really fused there at the end. So I'm going to show you a trick that I learned from Steve Safran, the innovative, amazing anterior segment surgeon that I'm sure most of you know, and that is to use an MST capsule retractor in the area of the adhesion. And what this does is it allows you to get the dissection more peripheral, and it allows you to be more aggressive in the dissection of the actual haptic because you're more confident that you're not pulling against the zonules. And here you can see we're able to get that distal portion of the haptic free. And now I'm just going to cut this in half. There's a lot of ways to remove the existing lens, but this is one way that I like, and that's just to use this MST disposable scissors and disposable IOL grasper and just cut the lens in half, and then pull the two halves out. And what we're going to do is we're going to place a lens that I really like in this situation, and that's the B&L LI61AO lens, which is an aspheric silicone lens, and so it has a different index of refraction. It's much thicker. It's much less likely to cause positive dysphotopsia. And so when we're doing the exchange, this is the exchange I tend to go to in this situation. This is Tom O of the University of Iowa. Thank you.